Let's reconvene, guys. Alex will be introducing our guest speaker.
All right, so it's with great pleasure that we have Dr. Neville, who's currently the Chief of Vascular Surgery at GW. He's going to talk to us about limb preservation centers and the challenge they face in our current healthcare economy.
Oh, thanks, Alex. Thank you very much for having me this morning, and thanks to Dr. Nakayama for inviting me. So what I'm going to talk about for the next half an hour to 45 minutes is sort of what we've come up with over the past 20 years or so in terms of treating people with problems that are affecting and threatening their limb. So I started out at Georgetown, and I was there for about 20 years and put this together over that period of time. About 3 or 4 years ago, I moved to George Washington, and so sort of starting over. So in a lot of places that ask me to give this talk, they're just getting started, so I always tell them I'm right where they are now as well. But I'm going to try to take what I learned over those 20 years and apply it so it doesn't take me another 20 years to get it going once again. So this is the enemy for the students and junior residents, atherosclerosis. We're going to try and fight the atherosclerosis so we don't lose the leg. And atherosclerosis occurs at bifurcation points in arteries, and that's due to hemodynamic reasons, things like flow turbulence, shear stress forces, increased particle residence time, things like this which cause atherosclerosis to form at bifurcations, at the femoral bifurcation and down in the tibial arteries. Diabetics preferentially get disease in their tibial arteries. So if you just look at an arteriogram, you can oftentimes tell the patient's medical comorbidities. What kind of symptoms are we going to be looking at? Well, this is not what we're going to be looking at. So this is claudication. And for the students in the room, if you don't learn anything else, please learn that claudication is not a limb-threatening situation. And a lot of interventions in the country now, especially some of the angioplasty and endovascular interventions, are being performed for claudication, and you sometimes wonder if they really need to be done. A lot of people think that the name claudication comes from the Emperor Claudius. He limped, and claudicare means to limp in Latin. It's a reproducible pain, so people get it when they walk the same distance every time. They don't get it when they walk half a mile one time and 3 steps the next time. It occurs in a functional muscle, and again, its significance is that it's a fairly stable situation unless you have diabetes or continue to actively smoke. So this is not who we're going to be talking about this morning. This is who we're going to be talking about this morning. People with limb-threatening ischemia. So they have rest pain. Now they have pain at night when they're trying to go to sleep. You're recumbent. Gravity's not pulling that little bit of extra blood down into your leg. Your cardiac output drops just a little bit because your venous return is down, because you're recumbent, your veins are pooling just a little bit, and people get rest pain oftentimes first at night. Paradoxically, they can get some rubor and edema in the ischemic leg because they hang their leg over the bed or they sit up in a chair to get rid of the pain, and they'll come into the clinic and I'll have the student go in and see them first, and they'll come out and say, oh, they've got, their veins aren't working well, they got a big swollen red leg. And what they don't realize is that sometimes that can be rest pain, and they get this paradoxic rubor and edema because they always keep the leg in a dependent position. And then hopefully we can stop this from turning into this. And this is usually what we're dealing with in our limb preservation center. This is tissue loss. So people have ulcerations or wounds that won't heal, or they come in with actual gangrenous changes. So people have coined the term CLI. This term gets bandied about a lot, sort of like MI. The cardiologists talk about MIs. We talk about CLI. And CLI is critical limb ischemia, but it's never really well defined. People throw this term around quite a bit without really defining it well. And what CLI is it's truly critical ischemic rest pain or non-healing wounds. This is critical lack of circulation. It has to be confirmed by some hemodynamic measurement. You can't just say, oh, I think they have it because I see a little wound on their toe. So you have to send them to some hemodynamic parameter, which is usually the vascular lab, which we'll talk about in a second. There's an increasing incidence in the country, and the goals of treatment are to increase healing and preserve the limb. There are huge financial implications of this problem, obviously. So these patients with CLI currently cost the country about $20 billion. The hospital stays for these folks are longer than they are for myocardial infarction and stroke. So if you come in with a non-healing wound, and we're going to try and fix you and then do all the things we need to do to get you to heal and treat all your medical problems and your infection and your heart disease and all those kinds of things, your renal insufficiency, your hospital stay, on average, is longer than the folks that come in and get admitted with MI or stroke. And average inpatient rehab, after we let you go home, is 9 months. So you can see where these costs occur and are continuing to occur. And that's not even taking into account the fact that diabetes is exploding worldwide. So diabetes is a major driver for critical limb ischemia, and it's just continues to be on the rise around the world. The Orient is seeing a huge rise in diabetes, India, China, Japan, and this country. So here's a typical case you might see in our clinic. Here's somebody that you come work in my limb preservation center that we're just getting off the ground at GW and just got some space, and we're going to get a sign on the wall. We're all excited. We've got some people that want to participate in the center, finally got some people to work together, which is not always easy, right, Dr. McCallum? We finally got some people to work together. This is the kind of patient you're going to see. You're going to see your 60-year-old African-American male comes in when his foot looks like this. And it's a non-healing site where somebody has already taken a toe, and the rest of the foot is now ischemic. He's got osteomyelitis in the toe. He's got diabetes. He's on dialysis. He's got congestive heart failure. And they've already tried a bypass at the famous outside institution, which has failed. So this is what you're going to be faced with. And 20 years ago, the reason I started putting together the center that we put together at Georgetown was I can't handle all this. I mean, I'm not the expert of his diabetes. I can't handle his dialysis. I'm not great at handling his congestive heart failure. I'm good at trying to fix his leg and getting more blood down there, and I'm getting better at fixing his wounds. But, you know, when you have these kind of patients, you really need multiple specialties with their expertise working on these critically ill patients. So, again, I can handle the revascularization. Some of the things we worry about and think about when we're thinking about these folks in terms of their revascularization is, should we bypass them or should we perform endovascular therapy? Do they have a good vein for the bypass? Sometimes we have to put pieces of vein together. And then we've come up with our theory about this angiosome theory, which has actually taken off quite a bit. But it's more than just the revascularization. Sometimes that's the easy part. You really have to treat their wounds. So you need somebody that can handle the soft tissue. You need somebody that can do their post-op and after they've healed, their foot care. That's critically important. How many times have we got things to heal, we see people come back and they now have decubitus ulceration of the foot from ill-fitting shoes or something that's not right. So you really need to get good foot care after you get them healed. They all come in super infected. They have all had multiple courses of antibiotics at other places. So you really need an expert in infectious disease, someone to manage their diabetes, dialysis if they need it, and you really need somebody very interested in their rehab. So you really need a whole team of people to really successfully treat these people and maintain the limb. So, in putting together our team now at GW, these are our goals. Our goals are to increase our success treating these patients with a multidisciplinary approach. We want to raise awareness that we can treat these patients. And when we first did this about 15, 20 years ago in Washington, D.C., at Georgetown, if you had diabetes or renal failure in Washington, you got an amputation. If you had a wound on your foot and you were diabetic or were on dialysis, you just got an amputation. So we really want to raise awareness that we can preserve these limbs, because if these folks lose their leg, it's more than just losing their leg. Their mortality at 2 years is about 50%. And their risk of losing the contralateral limb at 2 years is about 50%. So you're really doing more than just even saving that one limb. You're keeping them mobile. They're not so dependent on their family. They can often live independently. You can prolong their life as well. So really we wanted to raise awareness that we can preserve these limbs and maintain their life and their independent living status. You'll also serve as a referral source, let me tell you. Most people don't want to deal with all these problems. They might take a shot at it, but they'll get them to you pretty quickly. We also wanted to streamline their care. We tracked our patients, and it took our patients about 8 or 9 visits if we didn't have this center where they could come and everybody could sort of descend upon them. So if they had to go to each of these specialists individually, it took way too many visits for these folks to get their therapy. And as you might imagine, it's tough for them to get around. They're not the most mobile people in the world. So we were able to streamline their care. Now, we don't have that perfect yet, but we're getting much better at that. And then the question is, can we improve the financial viability of treating these patients? Do these programs matter? Well, they do. So Bill Jeffcoat is a good friend. He found that one of the key factors in lowering incidence of amputation in a nice study that he did was the presence of a limb program. Vicki Driver is another good friend up, and she just moved, actually. Vicki's now at Brown. She actually showed when she was at Madigan in the military that when they instituted their limb program, the number of amputations decreased and the extent of amputation was much more distal. They did many more toe amputations instead of above knee or below knee total limb ablations. So couple good studies have shown that these limb programs do result in success. And there's, as I said, worldwide interest. I've been over to China a couple times. The Chinese are now seeing this exploding. In China now, the hot spot in Beijing is Kentucky Fried Chicken. It's got lights and things are going on blaring, and they're trying to entice you in. And so everybody smokes. So you walk down the street, everybody's smoking, and they're eating Kentucky Fried Chicken. So they're starting to see an explosion in vascular disease. And it was interesting. So I was at the dinner with these guys one night, and at that time we were calling it our limb salvage program. And the chief of the first Peking hospital looked at me and he said, why do you call it a limb salvage program? And I said, well, because we're salvaging the limb. He goes, oh, you cannot do that. I said, oh, why can't we call it a limb salvage program? Apparently in Chinese, the Chinese character for salvage is the same one they use for garbage truck. So he said, you have to change the name. The Chinese people will not come if it's a salvage program. So which is a good point. So we changed it to preservation, based on his recommendation. So now it's limb preservation program. But the key is we really want to take it from just a wound care unit, which they had up and running quite nicely, to a limb preservation center. There's a lot of implications to that, which we'll talk about in just a second. And these are the key components of your limb center as opposed to a wound center. You're going to need staff, space, excellent state-of-the-art diagnostic imaging. You're going to have to offer all the forms of therapy, endovascular and open surgery, and excellent wound care. I mean, it's so frustrating to perform a revascularization and everybody's high-fiving coming out of the operating room, boy, we did a great case, and then lose the leg or lose tissue because of bad wound care. So that's very frustrating. Electronic medical record, you can't avoid it, you got to live with it. And it is very beneficial for the wound work. Lends itself to research. Oh my gosh, because you're collecting data on all these folks. It's a great tool for research. Marketing, we struggle with that. But it should be a tool. You should be able to market this entity. For some reasons, hospitals have difficulty marketing things. And then, as I said, last couple slides will be on my thoughts on the financial analysis of these centers. So here's your staff. You need a director. You need somebody who's going to be there every day running it. It can't be you or Alex or Pam. It has to be somebody on site, the program director, who's going to administer it. You're going to need a whole cadre of physicians. You'll need some physician leaders. I always say whoever has the passion. It doesn't have to be a vascular surgeon. It doesn't have to be a podiatrist. It doesn't have to be a plastic surgeon. It's different in different places. It's whoever has a passion for preserving these limbs. Everybody else will fall into line if you can set this up. You'll also need physician extenders. That's critical to see the volume of patients you need to make this financially viable. And we found the ratio to be about 1 to 3. And you'll need, obviously, support staff. You'll need the space. Since you're a 1 to 3 physician extender to physician ratio, you'll need the space to be able to see these patients. You'll need a vascular lab on site, which is also a revenue generator. So that's actually critical. Almost all these patients need a non-invasive vascular laboratory study. Hyperbaric oxygen. I'm not a huge fan of it, but it's needed. You need to do it. You'll use it with a certain percentage of your patients. It also helps the financial viability of the center. It would be nice to have these in close proximity to where we are, but we're struggling with that currently. Our operating rooms are overflowing, and so we oftentimes have trouble getting in. But it would be nice to have a dedicated OR. At Georgetown, we did work to that eventually. We had 2 ORs, which were just for the limb team, and that was really nice because these people need multiple debridements. They need revascularizations on a timely basis. You don't want to work off the ad list tomorrow night. You do these distal bypasses starting at 8 o'clock at night. So this would be nice if we can work towards that. Again, I won't belabor this, except this is a critical piece of what we do. You know, you'll have venous wounds, you'll have arterial wounds. Sometimes about 15% are mixed arterial and venous. And we really rely a lot on the vascular lab to tell us, you know, what's the etiology of the wound? Do we need to intervene? So here's a wound with some granulation tissue there. Do you need to bypass this patient, or can you just do wound care here? And we still struggle with that. We still struggle with good ways to assess tissue perfusion. So any budding engineer, bios engineer out there, if you can help us figure this out, it would be great. Right now we use TCO2s primarily, but they have problems. This SPY Elite camera, which I think the breast surgeons and the colorectal people use, we're starting to work with and getting some positive results. But we struggle with a good way to really assess tissue perfusion to tell us if we should just do the wound care or nope, we need to get more blood into this foot. You'll need to have CT angiography, although I got to tell you I'm not a huge fan of CT angios. I don't know how they are here. They're great for proximal arteries, but for the distal circulation, which we need to see, sometimes they're not as good as I'd like them to be. It seems like everybody gets one. You come to the GWE ER, you're getting a CT angio. I know, you come in with a cold, you're going to get a CT angio. But they're okay. I use them on occasion. MR the same way. I use it on occasion. It's great for the proximal vessels, but distally, it can't show me this kind of architecture that I need in the foot. So we still do a fair amount of catheter-based arteriography. You can see about half of them we will intervene at the time. So we still do a fair amount of diagnostic arteriography. And when I give this talk to cardiology groups, they're always like, well, we can just fix it at the time. We always just fix it right when we're there with the catheter. But a lot of these are complex lesions and require some thought, and I just don't fix. About half of them I can fix at the time, and the other half I have to think about it and decide what I'm going to do. So you're going to need both endovascular and open capability. You can see this is a slide that everybody uses when they give these kind of talks from Phil Goodney, the New England Vascular Group. You can see the number of endovascular interventions in the country and the number of bypasses in the country. So, a lot of people, I remember a good friend of mine, Mike Silva, who's down in University of Texas right now, he came and gave a talk when we were back at Georgetown, and he said, in front of the whole thing, he goes, I'm sitting in the front row, he goes, Rich, he goes, put your knife away. You're never going to do bypasses again. It's all going to be catheter-based. He's a big catheter guy. He says, we're never going to, you'll be a dinosaur if you're still making incisions on the leg. Well, I'm not sure that's entirely true, and I'll try to show you why. In our own practice, it's sort of paralleled the same changes. So here you can see the number of vein bypasses I do, 2000 compared to 2012, has gone down. The number of endovascular procedures has gone up. And this is the kind of bypass we do when we don't have a vein, which I'll show you a couple slides on. And this is about where it's going to, I think, sort of even out for us. I'm going to probably do about 3/4 of endovascular interventions, and still 25 to 30% of the patients I think are best suited for a bypass. Now, unless some game-changing devices, just, unless the drug-coated balloons or the drug-eluting stents or the bioabsorbable stents change the world, I think this is about where my ratio is going to fall. We do all the forms of endovascular therapy, although our workhorse is angioplasty. I think still angioplasty with stenting is the thing we do the most. I've not found laser atherectomy to be particularly effective. I tried cryoplasty and thought it was terrible, and now there's results have shown that that's true. And we tried atherectomy, and we use it selectively in certain situations, but our workhorse is still just angioplasty with stent deployment. And these are the patients we still bypass. So if you said, well, gee, who's that 30% of patients that you're still going to take to the operating room? It's patients with long total occlusions. So these are like long SFA occlusions, but in our case, with the limb salvage or limb preserving patients, it's mostly long occlusive tibial disease. People that have failed endovascular therapy in the past. Or patients with a large amount of tissue loss when they come in. And I'll show you a couple slides on that. Or to get to the appropriate angiosome. So those are the categories if the people fall into some of these categories, we might go right to a bypass. This is the data we found on amount of tissue loss at presentation. So we took 290 of our wounds. We had good data on them. Half of them had a bypass, half of them had endovascular therapy, and we divided them into groups based on the size of the wound when they showed up in the clinic. The group A were the little ones, and the group C were the large wounds or large volume tissue loss. And what you can see is the type of revascularization, bypasses seem to do better, but the key data point to this analysis was that the larger wounds, the group C, the bypass patients did much better than the endovascular patients. And this is the only group which reached, statistical significance. So in our particular practice, if you come into the clinic and you have a 2 centimeter or greater chunk of gangrene or an ulceration, and especially if you've got a saphenous vein, we're going to probably take you right to the operating room for a bypass instead of trying angioplasty and those kind of things. Then we came up with our angiosome concept. So I'm sitting in the lounge with the plastic surgeon that I worked with at Georgetown, a guy named Chris Attinger, who's a great guy. And we were talking about a patient, and he said to me, well, I need you to bypass to this artery. And I said, well, it's harder. I want to bypass to this artery. It's easier for me to bypass to this artery. He goes, well, I need you to bypass to this one because that's the artery that feeds where the wound is. And I said, well, Chris, that doesn't matter. I mean, in our vascular literature, we never thought that mattered. You just bypass to the best artery you could, and don't worry, the blood's going to get down there and mix around and everything will heal. He said, no, you're wrong. So he tried to convince me, and he did. So he convinced me we looked into this angiosome theory, which actually comes from the British plastic surgeons. So there's 40 angiosomes in the body, which are three-dimensional chunks of tissue which are fed by a single end source artery. And we went to the cadaver lab and we defined 6 in the foot and lower leg. So there's 3 off the posterior tib, 1 off the anterior tib, and 2 off the perineal. So here's the one we injected latex dye. Actually did this University of Maryland's lab, Alex. Injected latex, and you can see this is the anterior tibial injection and the dorsalis pedis. Here's the 2 that come off the perineal, and here's the 3 angiosomes in the foot and lower leg that come off the posterior tib. And then we decided, well, does that matter? Okay, that's pretty cool to do, but does it make any clinical significance? So again, we have got good data because you're tracking these patients, and we went and looked at a subset of patients, and half of them, almost half, 53% had a direct revascularization. So we had bypassed, and these are all bypasses. I didn't want to muddy the waters with endo versus bypass. So these people had a bypass to the artery which supplied where the wound was. And these folks had a bypass to the best artery I could find, but it didn't directly supply where the wound was. And what do you think happened? Well, if you got a bypass to the artery that supplied where the wound was, you had 90% healing. Otherwise, you had 60% healing. And that did reach statistical significance. So that's just another thing we factor into the mix. So just again, to summarize, if you come into our clinic and you have claudication or rest pain, I think those folks are very good for an endovascular approach if that's possible based on their imaging. Or if they have these task A, B, or C. Task is a classification, a way so that we can, so Alex and I and Pam, we can talk about apples and apples and oranges and oranges. When we know, if we say task A, we know what kind of arterial disease that is as compared to task B, C, or D. So the lesser lesions, A, B's, and C's, probably are good for endo. The more total occlusive longer lesions, probably best for a bypass. Poor medical risk, probably best endo, less invasive. And if you can get to the right angiosome, which is sometimes easier with an endovascular procedure. The endovasculars have really picked up on this angiosome. This is red hot now in the endovascular world. Then that may be appropriate for endovascular therapy. But then cost is on the horizon. Who knows what's going to happen with cost? I think with accountable care organizations and bundling of payments, we'll have to see how cost affects these kind of choices. There is an excellent trial being done we're participating in to try to define this problem, but it'll take several years. Okay, so now, when we do a bypass, if you're going to work in one of these centers and you're going to be the vascular surgeon, you're going to have to do bypasses, about 25–30% of your patients. And for the students in the room, when we think about a bypass, we want to first think about the inflow artery, where we're going to get the blood, the outflow artery, where we're going to take the blood, and the key thing is how we're going to get it there. We always struggle with the conduit. And when you work in a center, you're going to have a lot of patients that don't have a vein to use for the conduit, which is the best thing to use. If you've got a saphenous vein, I'm using it. But if you don't have a saphenous vein, then we have to struggle a little bit. And in the past, there was a certain body of literature which said, just amputate that leg. So when I trained with Bob Hobson, who was my mentor, who was a wonderful, wonderful guy, and I remember Bob arguing with Frank Veith, who's another wonderful guy, a little more irascible than Bob. But when I was the fellow, these two guys would argue for days on end that if you didn't have a vein, oh, well, just do the amputation. No, try this, try that, just do the amputation. So we had to think of something. So we thought of prosthetic grafts. There are certain prosthetic grafts out there. The problem with prosthetic grafts is they fail fairly rapidly, especially to the small arteries of the lower leg. And we know why they fail. They fail because of this myointimal hyperplasia that develops at certain portions of the anastomosis that we know. It's been very well defined clinically and scientifically. We know what it's from. It's a vascular smooth muscle, sort of gets stimulated, it proliferates and migrates, and this is what it looks like when you cross-section it. So we know what the problem is. And many people have tried to figure out different ways to get around that problem. They put pieces of vein and done the distal anastomosis in different ways. And I tried all these ways, and they're just hard to do. I didn't like any of them. They were technically demanding. I wasn't happy with the results. So we came up with our own way. So this is our vein patch technique. We call it the distal vein patch. So if you don't have a vein and you need a bypass to save your leg, I'm not going to do an amputation if you don't have a vein. I'm going to do this. So we take a little tiny piece of vein, wherever we can find it, and we sew it on the tibial artery, about 2 to 4 centimeters, and then make an incision in the proximal part of that patch. And every vascular surgeon knows how to do this. It's not hard like all these. Every vascular surgeon knows how to do a simple patch angioplasty, and then you put the prosthetic graft into that patch. So here's the graft, here's the incision in the vein, here's the artery, and here's what it looks like when we're finished, and there's the completion arteriogram. And we've reported our results, the first 80 patients with pretty good results out, but we didn't have many patients out for very long. I'll skip that one. So we recently reported we now have 290 of these cases. These are all to the tibial arteries. These are all to the arteries down, the small ones below the knee. These are not fem-pops. And we had many more patients out to 4 years, and we had a 50% patency rate at 4 years, which is reasonable. So if I see somebody in my clinic and they need a bypass, and they've got a large volume of tissue loss, they don't have a vein, let's say they've had a bypass at another place, so they've used their vein already, they've had their heart operated on, the heart surgeons beat us to it, Zach got there first and took the vein. I'm going to tell them that I can do my distal vein patch technique, and there's a 50-50 chance it'll still be working at 4 to 5 years. And oftentimes, even if the graft fails, they'll still maintain their limb, because if we can obtain healing, then they have enough collateral circulation, even if the graft fails, to keep the limb going. So the limb salvage, or the limb preservation rate, is actually even higher than this. So we think it's a good option. And then the next thing that came along the line was heparin bonding on these grafts. So the Gore company, I think Chuck's in the room, the Gore company figured out a way to bond heparin to these grafts. Why would you want to do that? Why do you want to put heparin on the inside of a graft? Well, it will prevent platelets from sticking to start the coagulation process, stop clot from forming, and it may even prevent that hyperplasia that we're talking about. Here's an animal model. This is no heparin bonding, and you can see the hyperplastic layer here. Here's heparin bonding, much thinner hyperplastic layer there. So there seemed to be some advantage to using these heparin bonded grafts. There was good data, initial data from Europe, that they worked well. So after we saw this, we put the first one in the US in 2006. I still use my patch. I don't trust this graft enough to do it without the patch and just take it by itself to the tibial artery. But we do think that the heparin bonded graft adds something beyond just the standard prosthetic grafts. So here's the proximal anastomosis. Here's the distal anastomosis. You can see there's already a scar on the leg, so it's probably a reoperative case. And if you look at our experience, we've just recently reported this. We looked at a contemporaneous set of patients, about 112 altogether, in whom we had good follow-up. So we get great follow-up on all these patients. We had 60 of the heparin bonded grafts with the patch and 50 vein grafts. There were more bypasses, more prior bypasses, obviously, in the heparin bonded group. That's why we're using a prosthetic graft, because they don't have a vein. And this is what we found. So again, if you've got a saphenous vein, at 1 year, your patency or your success rate is going to be better. So there's no question. But the heparin bonded graft with our patch was pretty close. So if you've got a vein, again, I'm going to use it. But if you don't, we will not go right to an amputation. I'm no longer using arm vein. I'm not harvesting lesser saphenous vein. I'm not stringing bits of vein together. We will, if they don't have a good quality autogenous ipsilateral, contralateral, greater saphenous vein, then we will have very low threshold to go to this heparin bonded graft with my patch. The other nice thing about the graft is you can do it quicker. It's 2 small incisions. You don't have the incisional morbidity of the vein harvest in the leg. So there's some other considerations as well. The only group in whom there was a statistically significant difference was those with renal failure. So the folks with renal failure, and you might imagine that the renal failure folks have very heavy calcifications and very difficult arteries to work with sometimes. So they did statistically better with veins. But they're the guys that never have veins because they've been used for fistulas, and so they're the one patient population that rarely ever has a vein is the one that needs it. So again, we don't hesitate to do the vein patch with the heparin bonded graft in the dialysis patients, but we realize that they're not quite as good as if we could use their own vein. The wound, and then the wound care. So now we've done the revasc part. So you're going to send them to the vascular lab. You're going to determine who needs revascularization for healing. Then you're going to decide whether they should have an endo procedure or a bypass. And then after you perform the revascularization, you've got the blood flow reestablished, then this is critical. Then you need somebody to do the wound care. And either you're going to do it, or get a plastic surgeon or a podiatrist or somebody that has an interest. At Georgetown, my friend Chris Attinger wanted to do it all. He said, don't you touch it. You just do your bypass and go away. But at George Washington, I'm having trouble getting somebody that's interested in it because these are tough patients. We just hired a young plastic surgeon who I'm hoping has an interest. But I'm learning it. I'm relearning it. So I'm once again the wound care guy. And what we're trying to do is maximize length, biomechanically sound, and oftentimes you need to do multiple procedures on these patients. They need multiple just debris. You got to get rid of dead tissue. Always take the dead tissue. Don't think it's going to come back. Don't think you're saving something by not taking it at the time. If it's dead, take it. And then we're very fond of delayed closures to make sure that the infection is eradicated. We do cultures before we close and make certain that when we put things together, it's clean and it's got good perfusion and on its way towards healing. And then I was a little skeptical at first, but the VAC's a wonderful thing, and I'm sure you guys use it a lot of times too. I was like, what? We're going to put what on what? But it works. So, and you need protocols. I won't go through them all, but you really need some standardization of wound care. So you can't have somebody come into the clinic and then they're going to get treated this way by this person and this way. You really need to come together and put your heads together and figure out how you're going to approach these patients. Again, debris to viable tissue. Again, this is critical. Don't reconstruct the soft tissue until the inflammation is gone, the infection's cleared. Don't put it together and hope it heals, because then you'll lose more tissue. And again, I'm getting to be a bigger and bigger fan of the VAC. And if obviously they come into the ER and it's wet gangrene, if it's infected, you got debris right away. The VAC we talked about. And sometimes amputation is the right thing. I mean, don't get me wrong. I mean, for a certain set of patients, do the amputation. That's the case I did yesterday before I drove here. A gentleman who was bedridden, had an above-knee amputation on the other side. He had a foot with a large amount of gangrene. We had a long discussion with the family. He had a target. I could have revascularized him, and then we could have, I think, saved the leg for him to pivot on, because he had an above-knee amputation on the other side. Sometimes if you can save the one leg, at least people can pivot. But he didn't want to go through all that. The family didn't want to go through all that. He was mildly demented, really non-ambulatory at this point. He didn't get out of bed very much, so we just did a primary amputation. So, and a well-done amputation is still a critical part of the program. And so you're going to have to learn all the amputations. All the various midfoot, hindfoot amputations you need to be familiar with. And you need to do a good below-knee amputation. So a below-knee amputation is not something that you, sorry, don't mean to insult anybody, but you send the intern in and say, let me know how it goes. That's a recipe for disaster. I've seen the results of that. So a well-done below-knee amputation is a great operation and can make a very functional patient. The posterior flap is key. You have to take great care to design that posterior flap properly so it's not too bulky here and it comes up nicely. And there's some other things. But just if you're going to get into this, you're going to need to learn how to do amputations well. We're starting our patient support group. We hired a prosthetist who has a couple guys that he works with who are they're amputees who are doing amazing things. Matter of fact, I was watching after dinner last night. I was watching the news, 60 Minutes or something, and I didn't know about this, but there's I guess a lady in Colorado who's an amputee who was on Dancing with the Stars. Did you guys see this? I don't know. I haven't watched that show, but she was an amputee. We got to get her for a meeting. She was an amputee, and she's on TV dancing. Oh, that is great. So the last couple slides, this is what hospital CEOs want to talk about. So this is everybody wants to know. Does this make money or lose money? Because these outpatient independent wound centers can lose money. And they're very, very dependent on hyperbaric oxygen therapy, which some people think highly of and some don't. So if you turn it from a wound center into a limb center, is that a financially good thing? So to assess that, we looked at the GW situation, and I hired some people to help me do this. We looked at our situation to see if it would be financially viable, and that's where this comes from. So you have to look at the direct costs, the indirect costs, and the revenue you're going to generate, obviously. In terms of revenue, you're going to have center-generated fees, which will be the technical component, and you're also going to have fees to your docs. And then the key thing, and a lot of hospitals don't want to tell you about this. Georgetown would not tell us about this. They guarded this number like it was the Holy Grail. They will not tell you what they generate in terms of downstream revenue. Now, GW has been very forthcoming and is giving us some insights into that. So the direct and the indirect costs are not cheap. You're going to have to put a lot of money into one of these centers to get them started. You're going to have staffing expenses, all kinds of non-staffing expenses, which are your materials, keeping the lights on, heating the place. If you decide to have a management company come in and help you, you're going to have management fees. So you're going to have certain not insignificant fees up front. If you do just the outpatient wound center, then the two things that are going to drive your revenue are going to be debridements. So you're going to need a room or two to do debridements in the center. That's pretty critical because a lot of times these people, you don't need to take them to the OR. These are debridements. A lot of them can't feel much at that location anyway. You're just debriding some dead tissue. They need multiple debridements, maybe in combination with hyperbaric or dressing changes or vac changes. So multiple debridements is critical, and the hyperbaric therapy at this point in time is a financial driver. Then you've got to track this downstream revenue. And the two biggest places where you're going to make downstream revenue are the inpatient surgical procedures and the associated medical admissions. So inpatient surgery, you're going to have your vascular reconstructions, amputations, any kind of soft tissue work, and it will generate significant revenue. And then you're going to have associated medical conditions. These folks have diabetes, congestive heart failure, heart problems, all kinds of things that will also require inpatient evaluation and treatment. So if you put this all together, our analysis, at least initially, and this is why they decided to go forward at our center, is that it can be financially viable. Even the first year, you're going to turn a profit, and by the end of 4 or 5 years, you should be generating a significant profit. Now, that's all things being equal, making sure that, assuming that hyperbaric therapy doesn't continue to drop in terms of reimbursement, and who knows what's going to happen with that. But the current state of the art, if you factor in the downstream revenue, you perform debridements in your center, you have the capability to perform hyperbaric oxygen therapy, you should generate significant positive cash flow for the hospital. As a matter of fact, so we opened our doors for our new limb preservation center at George Washington about 6 months ago. We actually opened the door. They're still doing some renovations, but in 6 months we've doubled their revenue and doubled their volume. And we haven't even marketed it yet. We haven't even told people. This is just in-house stuff that people said, oh, great, we'll send it there. We don't want to deal with it. And we've already doubled the volumes and the revenues. So the hospital, I think, is seeing that it can be a good thing if done properly. But all bets are off if this happens. So this is on the horizon, the accountable care organizations. Bill Ennis, who's a friend up in Chicago, gives a great talk on this. Bill's done a wonderful financial analysis on the world of accountable care organizations for the wound world and the healing world. And, nobody knows for sure. Obviously, in this world, it's going to be critical to have standardized guidelines so you keep everybody on the reservation. You can't have somebody going off here doing crazy stuff, and you're going to really need standardized care in order to make it financially viable. We're going to try to get to patients early. It's a lot easier to treat them, quicker to treat them, easier to treat them when they've got rest pain or a little ding on their toe than when they come in with the whole foot filled with gangrene and wounds. We desperately would need to improve preventive measures and patient education. I mean, it always amazes me that somebody sits at home until their foot is like falling off. But I think they think nothing can be done, and that's our fault. So people don't realize that something can be done. So we still need to do a lot with education. And I think some of this care is going to be driven to those centers that show they can do it effectively, successfully, and in a viable manner. And I think the key to these things is going to be this, instead of just a wound center. I think if you can really get the appropriate specialties to come together, work together, get a couple people that are really passionate about it, get the support of your administration, I think there's a real opportunity to make a real mark, to help a lot of people, and to have a financially viable entity. So it's multidisciplinary, somewhat labor intensive. You're going to have the difficulty covering your outpatient costs by themselves. You're going to need to track your downstream revenue. You're going to need to attract inpatient admissions, and you're going to need to go from here to here. And if you do, I think you'll still do bypasses. I think you'll do a lot of endovascular work, a lot of diagnostic vascular lab work, and you'll have a very nice center. So thank you very much for your kind attention. Appreciate it. Sure.
Anybody have any questions?
So in your experience with these limb preservation centers, are there many in rural areas?
Well, there's not too many at all at the moment. So most of them right now are wound centers. And that's, so the question that always arises is should we start a limb center or take our wound center. I was just up in Michigan, so they had a very nice wound center. Do they maintain that and build a limb center or convert the wound center into a limb center? There's very few actual limb centers at this point in time. And again, all politics is local. It depends what your resources are and what you have to work with. But right now, there's very few limb centers, to be honest with you.
I think about our catchment area.
Yeah.
I think about 1 million people.
Yeah.
But dispersed over hundreds and hundreds of miles.
Right.
It's pretty difficult terrain. How effective a preservation center would be versus a wound center?
Right. That's a great question. My only thoughts initially to that as I was driving here today, yesterday, was so what we're going to do in Washington is we're going to work with one of the wound center companies who realizes that for their benefit they need to make this transition. And we're going to establish the preservation center at George Washington, and they're going to put outreach wound centers, satellite wound centers, where you'll have a physician or a physician extender who can follow the patients there, do the debridements. Maybe they're even thinking about putting hyperbaric chambers in those centers. But see, that'd be perfect if you could have some satellites where people could get to, but, oh, you need a bypass. Gotta come down now. Yeah.
Dr. Nakayama, sorry.
Yeah, I think this lends itself to multidisciplinary treatment. Practically speaking, is it more like a multidisciplinary cancer center model where you have a patient being seen by serial providers and then the case gets discussed, or practically speaking, is it something that is more these different specialists in isolation and coming together? How integrated?
That's a great question. That's a great question. And so at Georgetown, it took us 15, 20 years, but we finally got it very integrated. Somebody would come and they'd go in a room and Chris would go in and see him, I'd go in and see him, they'd get their vascular lab. So starting it again at George Washington has been a struggle. That's what we're working towards. I think for these folks, as I said, we need to streamline their care. They're not very mobile. So the whole idea is so they can come and be seen by the wound person, the vascular person, the plastic surgeon, even maybe the infectious disease person is critical. So that's the goal, and we're getting there. So right now we just hired a great wound nurse from Walter Reed, and even if the plastic surgeon, who sort of says he wants to head up the soft tissue work, even if he's not there, and he'll come running down, but even if he's not there, Kara, the wound, she's always there. She's great. I mean, she's treated all these guys coming back from overseas. So if I go in and see somebody, I'll say, hey, Kara, come, we go see them together. And so the goal is that they are seen by the team. But as you might imagine, the other thing that we've now been dealing with, which we didn't have to deal with at Georgetown, is, because the model's a little different, is reimbursement issues and billing, and people are concerned who's going to bill, who gets to bill, is this all in one pot, are we all doing our separate thing? So those are issues we're now starting to face.
In your model, it sounds like hyperbaric is is that piece in your model managed by a management company who owns the hyperbaric chambers and then you just contract with them?
Yeah, excellent question. So right now it's not. Right now it's run by 3 of the ER docs are hyperbaric certified. So when I got to George Washington, they had chambers already. They're using them. We've increased the chamber volume, but I don't use hyperbaric a huge amount. But we've increased our volume somewhat. But this company that wants to establish us as the hub and put the satellites out there wants to run the chambers. That's what they want out of the deal. So we're negotiating with that. I'm not sure which way the hospital is going to go. I would like to have, just between us, I would like to have the management company, I'd let them run the chambers, and if they'll put in the satellites, they'll build out the satellites, they said. So I would say, shoot, let them run the chambers. I don't think the hospital makes that much money off the chambers. Maybe they do. I don't know.
Georgetown, was it something that was run by the hospital?
At Georgetown, what happened? At Georgetown, we didn't have hyperbaric, believe it or not, for a long time, and we would send them to GW. So not recently, but a little before I left, and I've been at GW 4 years, so probably 5 or 6 years ago, they finally got chambers, and they contracted with one of the companies, Healogics, to just run the chambers, not manage the center. They didn't want to give up management of the center, and so they managed the chambers at Georgetown. But they paid for them, put them in, all that kind of stuff. So right now, what we're struggling with was, do we let, and we're also talking to Healogics, so do we let Healogics manage our center and run the chambers and put in these satellites, or do we try to do it ourselves?
I have 3 questions for you.
Okay.
The first one is, when I was in the VA with Steve Santilli in Minneapolis, we did a study on limb salvage, but we focused more on the quality of life for the patients.
Right.
So they were given SF-36 forms,
Right.
and the idea was try to understand, do we really improve the quality of life, and is there a difference between primary amputation versus revascularization? And unfortunately, we didn't find any significant difference in the SF-36 score
Right.
after successful limb salvage or successful amputation. So I was wondering if you would have some insight and direct our process. I mean, is there some certain factor we should be looking at before we schedule a patient for limb
Yeah,
salvage?
no, that's a great question. And the Greenville guys have looked at that too. Spence Taylor and those guys and Gene Langan have written a lot about that. You know, and they found the same thing. So when they looked at their data, the 2 most predictive things, I think, were in patient satisfaction were, did they come from a nursing home and were they demented when they first came into the hospital? It had nothing to do with saving the leg or anything like that. So you're right. So we struggle with this. But so my philosophy is, you know, sometimes primary amputation is the right thing. No question about it. And I'll suggest that to people. And it's a judgment call, Alex. I don't know. I still think if you can save the limb, there's very good data to show that you prolong their life, you keep them mobile, you save the other leg most times. They don't get pneumonias, they don't get bed sores, they can live independently. So I still think there's great advantage to saving the limb. But, you know, I think it requires some significant judgment. Sometimes primary amputation is the right thing. No question about it.
Yeah, I thought was also that the instrument we used to assess quality of life was not sensitive.
Yeah, that could be.
Because of multiple comorbidity.
Yeah.
Anyway, my second question is technical. I know that when Taylor proposed his patch in the 90s, the idea was to improve compliance of TFE
Yeah.
graft, and you recommend doing a patch not only at the distal anastomosis but also at the
Right.
proximal.
Yep.
What's your thought on that?
Well, so give up that Taylor thing, first of all. It's too hard. It's too hard, and I won't pull the slide back up, but I tried his thing. And, you know, half of his patch is, the prosthetic is still on the artery, and there's a triangulated point where when you get a completion arteriogram, it's narrow. But anyway, I won't ding Dr. Taylor because he's not here. But yeah, we looked at compliance. So we did a study when I was with Tony Sadawi at the VA. We looked at compliance, looking at these cuffs and patches, and we didn't find compliance to be a major issue. So I had a couple slides on the hemodynamics. I breezed through them. I think the reason the patch works is not compliance. Maybe a small role. I think the reason the patch works is autogenous biologic tissue, which has something. I don't know if it's nitric oxide. Nobody's identified. There's something in that autogenous tissue that helps. And then also we did some very nice hemodynamic studies that shows the hemodynamics through the anastomosis is much improved with the patch as opposed to the other forms or a straight prosthetic. So I think it's a combination of I'll come back and give you I got a whole hour talk on that. It's a combination of biologics and hemodynamics, and it's not compliance. The main thing is not compliance, yeah.
My third question, that's...
He's on a roll.
I understand the concept of the limb preservation center and to have actually a location for all of us to practice this, but do you have to restrict your practice solely to limb salvage?
That's a good question.
I mean, we have clinics on certain days,
Yeah.
and yet your center is open 5
Right.
days a week.
That's a great
So
question.
if you're going to see the vascular surgeon, plastic surgeon,
Right.
I mean, is that what they do for a living?
Right. That's a great question. So 2 answers to that. The first answer is I do a clinic day in my office and a clinic day in the limb center, one each day. Because you're right, we still do carotids, aneurysms, yeah. And this will take up your time. And now that I'm actually going to do more of the wound care because we don't have anybody yet, I may give my partners the aneurysms because you can't. I mean, you can't. So in terms of how your time spent in the limb center, it is staffed with the ER guys that run the hyperbaric chambers and some wound folks. I'm there 1 day a week, so they try to funnel the patients that have a vascular issue to that day. The rest of the time, they bring them in, do the debridements, can have them come back for hyperbaric therapy, but they try to funnel the patients that have vascular issues to my day. I tried doing my other day in the limb center, but the carotid patients and the aneurysm patients don't like coming to the limb center. I mean, I think if we made it nicer, they would, and they will, but they don't like sitting next to the people with no legs and wheelchairs and things. But we may go back to that. Yeah.
Thank you very much. Try running a pediatric surgery clinic next to a limb salvage center. I thought it was great. Thanks again.
Oh, my pleasure, Don.
Neville.
Thank you. Thanks for having me.
And thanks for coming. This is
Oh, thanks. Oh,
us.
thank you.
Okay.
Appreciate it. Oh, sure, absolutely. Absolutely. Yeah, they're on the desktop.
And then,
Yeah.
crazy. It was a very productive session, and thanks a lot for coming.
My pleasure. Thanks for having me.
Thanks.
Okay.